everybody. This is Susan Summerall again with NAC State Affairs team. We are very glad to have you for our second session in our Accountable Care Academy 2020. We are going to cover some general considerations for under federal law for FQHC payment protections as we think about risk-based contracting and value-based contracting. What are some of the fundamentals that you all need to know as health centers and as primary care associations as you enter into those contracts? Before we get started, next slide, please, Kate. I want to remind you, so as I mentioned, this is our second in our series of 4 webinars. Our first was held on June 3rd and focused on risk-based methodologies. I believe that is available to go back and listen to at this point, but I will confirm that in the chat box for you all. And then we're obviously talking about considerations for FQHC payment protections today, but we have 2 more after today. On July 15th, we're going to be talking about value-based pay contracting safeguards. And then on July 29th, we're going to be hearing field representative stories. So hearing from your peers as they talk about the work that they've done in this space and sort of what are the lessons learned, some best practices there. And it will also give you time to engage with those folks and Adam Falcone, our legal expert on this, who's been a wonderful presenter thus far. So if you've not yet registered for these 2 webinars, you can definitely do that on the NAC website. There's also the links if you're able to sort of cut and paste those from the slide deck. So I'm going to go ahead and introduce Adam so you can get started. I think many of you know Adam Falcone. He is a partner with Fellows & Tucker Lifer Fidel law firm here in DC. He is by far an expert on risk-based contracting and FQHC protections, one that we go to more often than not with a lot of these questions as well. So we're very excited to have him to present in this series for you. I'm going to turn it over to you now, Adam, to go ahead and get started. Oh, one last thing. We're using the chat box for questions at this point. So if you have any questions, you can certainly enter them into the chat. If you wouldn't mind making sure at least sending them to all panelists, you can also send them to everyone, just to make sure, because we've got some folks helping behind the scenes to manage the questions for Adam. We're going to hold those to the end as they come in, but if you could just make sure to send them to all panelists, we will make sure to get your questions answered as you have them in. So with that, Adam, I will turn it over to you.
Thank you for coming back.
You may be muted, Adam. There you go.
Hello, everybody, and welcome back. Good afternoon, or I think it's good afternoon for everybody unless you're in Hawaii or Alaska. Welcome back, and thanks for tuning again for the second of the series in the webinar. I am glad you came back. And if you didn't hear the first one, you can always, I think, register and listen to it on demand. So today's webinar, we're going to focus on some general considerations under federal law, the Medicaid and Medicare PPS protections under risk-based contracting activities, and how some models might work under an APM. Before I begin, let me just remind everyone of the disclaimer that my thoughts today, the opinions expressed today, do not necessarily represent the opinions of NAC, and that I'm not providing legal advice today, but just for general information. All right, let's start first with the first poll question that's now up on the screen. This question says, which of the following payment methodologies involve no financial risk to the health center? And you'll see 5 options in front of you. So please make your selection now, and I'll give folks a moment to answer the question. If you can't see the slide and you're just tuning in, just so you know, it's, the options are capitation is A, B is PPS, C is fee-for-service, D is cost reimbursement, and E is none of the above. This is material from the last webinar if you're wondering where this came from. I didn't call it a quiz today, but you might interpret it as a quiz if you were on the last webinar. All right, probably should bring the poll to a close, see what the results are. can't see any results from coming up, so I can't tell how people scored, but I do see that the poll has closed. Is there any way someone can read to me if they can see the results of how people voted? If not, oh, there they are. Okay, so 12% voted for B, PPS, another 12% voted for fee-for-service, 25% voted E for none of the above, and none of the above have it. That was the correct answer, because as I shared in the last webinar, there's really no true non-risk payment methodology. Even cost reimbursement itself has some risk involved, to the extent that the funding entity or agency might disallow certain costs, or you might have costs that exceed some cap that's set on that particular type of cost, or you might incur costs that are not reimbursed by the funder. So to some extent, every kind of payment methodology known to mankind involves some risk on the provider. It's just a matter of degree. Great. We will move on now to the material. So as I mentioned, we're going to cover 3 broad topics today. First, some general considerations about whether health centers can take risk under value-based payments under federal law. We'll talk about some considerations that impact taking risk under Section 330 of the Public Health Service Act. And then we'll wrap up, it's been really the bulk of our time today, on payment protections for FQHCs in Medicare and Medicaid. So this issue comes up from time to time where people say to me, Adam, we're not quite sure whether health centers are even permitted to take risk under a value-based contract. Is that really, does federal, Medicaid law really allow health centers to take downside risk in contracting with managed care entities? I think it's helpful and important to answer that question right off. There is nothing in federal Medicaid law that would prohibit FQHCs to take downside risk. In fact, when you look at the law, as we did, there's actually a number of provisions in federal law which actually allow, if not give health centers the authority to take a downside financial risk. You can see these provisions in the Medicaid statute here. These are provisions in federal law that allow a health center to become a Medicaid managed care organization and contract for full risk, or receive a full risk capitated contract under other language under federal law. All that means is that an FQHC can take a contract at full risk with a state Medicaid agency. So our view is that if an FQHC can essentially become a Medicaid managed care organization and contract at risk, at full risk, there's no reason why an individual health center shouldn't be allowed or shouldn't have the same authority to contract at an at-risk arrangement with a Medicaid MCO. There's no logic that would preclude a health center from taking that risk if the health center alone could contract with the Medicaid agency at full risk. So I want to disabuse anybody who has this notion that health centers can't be in at-risk arrangements with MCOs, that there's no federal law that would prohibit them from doing so. Is it more complicated than that? Certainly, because everything is more complicated for health centers. You have state insurance law that applies to providers of any type, and that could impinge upon a health center's ability to accept risk of loss. Some insurance commissioners across the country in various states do take the position that any kind of provider who's in a downside risk arrangement has to be somehow licensed by the insurance commissioner of that state. Some states require these providers to have risk reserves, and to the extent that they might incur downside risk. Other state insurance commissioners could require the health center to have stop-loss insurance, because under state law, there could be a requirement that when a provider like a health center takes downside risk, they have the appropriate licensure reserves or stop-loss insurance. So it's always a good thing to check under state law. There could also be state Medicaid policies that bar a health center from being eligible to take downside risk. I wanted to give you an example today. It's not one that I actually agree with, the state's logic or rationale, but I wanted to show you as an example that in one state at least, like New York State, they don't allow FQHCs under their current policy to be so-called lead value-based payment contractors. That's a sort of a word of art under the state Medicaid program of types of entities that can enter value-based arrangements with payers, and they're not allowing FQHCs to serve as the lead value-based payment contractors in downside risk arrangements or under global cap agreements. So you could have a state policy that, for whatever reason, good or bad, right or wrong, also impinges on a health center's ability to engage in downside risk arrangements. But again, both of those considerations are under state law or policy and have nothing to do with federal Medicaid law, which does not contain any kind of prohibition. Next, we turn to 330 requirements under Section 330, and some health centers have asked, rightly so, how does Section 330 impinge on our ability to engage in value-based payment arrangement and take potentially downside risk? So I wanted to share with you some of the provisions from the 330 regulations because that provides some, I think, good guidance for how you can use your Section 330 grant funds as well as program income. So if you look at the first bullet point here, the permitted use of grant funds. As you know, you can only use your grant funds for activities that fall within your approved scope of project. And your approved scope of project most likely includes or covers activities relating to primary and preventative care. Some of you may have some specialty services that you provide, but the bulk and the majority of health centers provide primary and preventative care, and those are the approved scope of services under their scope of project. You can only use your grant funds for those activities. So would that impinge on your ability to engage in value-based arrangements? It wouldn't disallow it, but you wouldn't be able to use your grant funds for activities or for healthcare services that fall outside your approved scope of project. Let me give you an example. Let's say your health center has a value-based agreement with a Medicaid managed care plan, and as part of that value-based arrangement, you are at risk for the total cost of care for the attributed Medicaid beneficiaries. Now, of course, the total cost of care don't just include the health center's primary and preventative services. It would also include hospital services and specialty services. And let's say you had a shared risk agreement with that Medicaid MCO, you had downside risk, and the expenditures for that population of patients exceeded the benchmark that was set by the Medicaid MCO. In other words, the expenditures on the total cost of care exceeded the expected budget or benchmark the MCO had set. And you as an FQHC now owe money back to the health plan because you had that downside risk and you didn't do so well in managing that risk, and you owe money now back to the MCO. Could you use your grant funds to pay that money back? No. Why? Because that risk that you incurred, that downside risk, included hospital expenditures, specialty care expenditures, whatever else was part of the calculation for total cost of care. And your grant funds can only be used in regard to your services that fall within your approved scope of the project. Item 2, capitation payments. This says that this regulatory provision says that even if you render services to a managed care plan on a prepaid capitation basis, the grant funds themselves can only be used for the cost of delivering health services related to your approved scope of project. So let's say you have a primary care cap payment from a managed care company, and let's say just for the first example, it's totally consistent with your approved scope of project. So whatever you get from your cap payments, your primary care cap, that can be used towards your approved scope of project. And let's say in some event there was I'm trying to think of a reason that there would be a shortfall. Let's say there was just some shortfall in those capitation payments. Could you use your grant funds to subsidize those services? Likely you could, because it's consistent with your approved scope of project. And you can use your grant funds even when you render services on this prepaid capitation basis, so long as your grant funds are limited to your approved scope. But if the capitation was larger, it was for all professional services, and you were providing some services outside your scope of project, now you wouldn't be able to use your grant funds to pay for some of those services that are outside your scope of project, even though you're rendering those services on a prepaid basis. Reserve funds, are you allowed to use your grant funds for the cost of developing a reserve that might be required by your state? Yes, that's explicitly allowed by the regulation. Now we come to some downside risk issues and program income. If you do incur some downside risk, like in one of the shared risk arrangements I described on my last webinar where you're at risk for the total cost of care, would it allow you to use some of your funds to offset those costs related to that downside risk? It's possible. that, that you could use your program income, but you wouldn't really be able to use your grant funds. Why? Because, again, it goes back to what services are approved under your scope of project. You can't use your grant funds for things that fall outside your scope of project, as the letter to this health center director makes clear from the Bureau. But you could use your program to the extent that that taking that downside risk in that total cost of care arrangement furthered the objectives of the health center's scope of project. So we believe that in certain limited circumstances, if you take a reasonable amount of downside risk and it furthers your purposes of your scope of project, then it would be permitted. So what does that mean? Let's say you're in this downside risk arrangement for total cost of care because you recognize that if you do a fantastic job in managing high-cost chronic patients or patients who have been utilizing the emergency room as their, basically for primary care, and you are successful in redirecting them to your health center for those services and minimizing preventative hospitalizations, that's all in furtherance of your approved scope of project, because your purpose of your project is to ensure that the health center, is providing those services in the appropriate setting, and to avoid hospitalizations that, are avoidable through good chronic care management. In that case, you could use some program income that you generated to bear some of those downside risk in the event that you did have a loss under that kind of downside financial risk payment methodology with a payer. So to recap, you cannot use your grant funds to pay for any kinds of losses and any kind of downside risk arrangement for that relate to services that fall outside your scope of project. In contrast, you would be allowed to use some of your program income. That is, program income is that revenue, that third-party revenue generated based on operating your health center to bear some of the downside risk if it furthers the purposes of your project. So sort of a complicated answer there, but that's really the underpinnings that allows a health center to bear downside risk, and it explains what income you can use to pay for that downside risk. All right, let's move to the next poll question that just showed up on your screen, should be there now. It reads, a shared savings arrangement with upside-only risk would fall under what category of the Healthcare Payment Learning and Action Network categories of payment? A is Category 1, B is Category 2C, C is Category 3A, D is Category 3B, and E is Category 4A. I'll give you a moment to put in your answer. All right, just a moment more. This is probably one that you either know or you don't, or you're looking back in your notes from the last webinar to see what the answer was, because this is also from the first webinar from the series. All right, let's close up the poll and reveal how people voted. And I'll read you what the answer is while we're waiting for the poll results to show. The answer is that a shared savings arrangement with upside-only risk falls into Category 3A, which is option C. So those of you that voted option C would have been correct, because a shared savings arrangement that only has upside is 3A. 3B, for those that you voted for 3B, that's a shared savings arrangement with downside risk. All right, let's move on to the next slide. All right. Now we're going to turn to FQHC PPS protections in Medicare and Medicaid. We'll start actually with Medicaid. So I should say Medicaid and Medicare. Many of you that have been around health centers for a long time recognize that wraparound payments sometimes complicate when it matters when health centers enter value-based arrangements. So let's start with how wraparound works in the context of managed care. And then I have several slides that will show you how the calculation for wraparound is done if you take some kind of value-based arrangement, such as for involving pay for performance, shared savings, downside risk, or capitation. So the first thing to realize is that that your your protections under wraparound that make you whole to PPS apply whether you are participating directly in a contract with a managed care entity and taking some kind of in some kind of value-based arrangement, or you're contracting with a managed care entity through an ACO, an accountable care organization, or an IPA, or a health center controlled network. Regardless of whether there's an intermediary involved or not, your PPS protections sort of protect you as a health center and ensure that you're paid in full at a minimum your PPS rate for each encounter. The state has certain requirements. The wraparound is the state's obligation, and the state's requirements are to make sure that you receive that wraparound encounter to make you whole up to the level that you would have been paid under traditional PPS in the absence of managed care. The state has the obligation to make sure that you get paid that wraparound no less frequently than every 4 months. Some people refer to this as a quarterly requirement, but it's actually every 4 months under federal law. And then that the state has to conduct this reconciliation to ensure that you, at the end of the day, had received at least as much as you were supposed to receive under PPS or APM under managed care. So in some states you get paid by the managed care entity, and then you submit a claim, sort of a shadow claim to the state for wraparound. And then at the end of the year, the state conducts that reconciliation. They look at all the total number of encounters that you received. They calculate the amount that you would have received under PPS by multiplying the encounters by that PPS amount. Then they look at how much you received from the managed care entities, plus all the wraparound payments that had been paid to you on that interim basis under those shadow claims, and then they see if there's a difference and a delta. And if you haven't been paid enough because you had more money coming to you, then the state has to issue you an additional payment. If you got overpaid for various reasons, then you could owe, arguably, some money back if you received more than you were entitled to. Although it's a little bit tricky. You have to always keep in mind that this wraparound calculation is not to take money away from you so that the state makes money off of you. It's to make sure that you get paid in whole. And there's been some cases where health centers have been able to generate additional payments from payers, get paid more under certain circumstances. That doesn't mean the state is automatically entitled to that payment. PPS is a floor. It does not forbid health centers from earning less under arrangements with managed care companies, even in the context of earning wraparound payments. Question comes up in value-based payment arrangements is how does this work in the event that you get paid an incentive? And back in 2000, which is 20 years ago, the CMS, Centers for Medicare and Medicaid Services, came out with a policy that made clear that if a health FQHC received additional payments from an MCO as incentives, so pay for performance incentives or some kind of risk-bearing methodology where they got extra money, the state could not use that extra money that the health center earned to offset the state's wraparound obligation. In other words, the state has to keep any incentive amount outside of its calculation of supplemental or wraparound payments. Because, of course, doing so, if they had included that additional revenue, then it would lower the state's obligation to pay wraparound, and it would essentially defeat the purpose of the health center being able to generate additional revenue as an incentive payment. So CMS is very clear in the state Medicaid director's letter back in 2000 that states have to keep those incentive payments outside the calculation, that they should only calculate wraparound payments based on the baseline payment under the contract between the health center and the managed care entity without regard to any financial incentives. More recently than 2000, back in 2016, CMS reiterated that positive financial incentives paid by MCOs allow FQHCs to earn amounts over and above those that they are required to receive under the PPS payment methodology. So for those of you who want to see something more updated, that 2000 opinion and guidance when the CMS issued the final Medicaid managed care rule provides that additional information that allows health centers to earn amounts through financial incentives over and above PPS. So how does this apply in the context of various value-based payment arrangements? Let's take this simple example. Many health centers today have arrangements in which they earn additional money under pay-for-performance contracts. So here's an example where a health center would have earned a pay-for-performance incentive from a health plan. And let's go through the calculation for how the state calculates wraparound. Under this example, the first line in the slide shows you how much the health center received from the MCO. Let's assume for purposes of this example, the health center is compensated at 100% of the Medicaid fee schedule in that state, and they generate $75,000 through claims that they submit to the Medicaid MCOs. In addition, the health center has been able to earn incentive compensation through pay for performance at some rate of $50 per patient outcome. So let's say that, for example, in this example, if the health center provided all the recommended care to the patient in the course of a year, the health center earned an additional $50 per patient. And let's say there were 500 potential patients they could earn this revenue on, so potentially a health center could earn up to $25,000 in additional revenue. Under PPS, the health center is compensated $150 per visit, and let's say in this example, during the course of the year, they would have 1,000 encounters and generate, under PPS, $150,000. So the state calculation is very straightforward. You look at how much the wraparound payment is determined by taking the total compensation the health center would have earned under PPS, which is $150,000, deducting the amount that the health center received in compensation for base payment from the MCOs for FQHC services, which is $75,000, and then there's a balance owed by the state for $75,000 in wraparound payments. In this example, the health center would receive $75,000 from the MCO, $75,000 from the state in wraparound, earning their total of $150,000. But in addition to that, if the health center succeeds under the value-based payment methodology and earns all of its incentive payments, they could earn another $25,000. So total amount, $175,000 in total between payment for services and incentive payments. If they don't get the incentive, they lost the extra incentive of $25,000. They're just back to their base PPS, which is $150,000 for the services that they provided. This slide, which probably should have been one slide earlier, shows that recent Medicaid managed care language made clear that in addition to complying with any kind of state-mandated payment levels and methodologies, health centers have to comply with their conditions of grant funding. What does that refer to? That refers to those obligations that health centers have not to spend their grant funds on services outside of their approved scope of project in compliance with Section 330, and to use your program income only in furtherance of your project objectives, which should sound familiar to you because I went through those on the earlier slides relating to the Section 330 considerations. I point this out just to show you that in one of the rare instances that I see, CMS acknowledges a health center's obligations or a health center's payment rights under Medicaid, under PPS, as well as a health center's additional obligations under Section 330 of the Public Health Service Act, which is a different statute than the Medicaid program. Medicaid program laws are in the Social Security Act, and Section 330 is the Public Health Service Act, and you are subject to both of those statutes, both of those acts, and different requirements. And it's rare that in one rule like this, CMS refers to both, but they did here acknowledging that both of those requirements apply to FQHCs. The next example is a shared savings, shared risk arrangement. And as I mentioned in the last webinar, this slide should be familiar to you. In this kind of circumstance, let's presume that because this arrangement involves some downside risk, an FQHC prudently decides to join an ACO, an accountable care organization, to take the risk directly from the MCO for the total cost of care and not bear that risk directly itself. So in this example, you have an MCO contracting with an ACO, presumably with more than one FQHC participating in that ACO, but for purposes of simplicity, we'll just have one FQHC in this example. So in this example, the FQHC gets paid its base reimbursement, whatever that is, from the MCO. The ACO takes the risk based on the total cost of care for some attributed population of patients. If the ACO is successful in managing that risk, it earns the additional revenue from the MCO, and the ACO, which hopefully the FQHC sits on its board of managers or board of directors, and the ACO distributes that additional revenue to the FQHC that it earns for managing that risk. And the FQHC also earns wraparound payments from the state Medicaid agency to bring up its individual payments up to PPS levels. And so this is how the math works out in that kind of example. The first line here, like in the last, is the amount of money the health center earns from the MCOs. and let's assume for this purpose, again, they're reimbursed by the MCOs using the state Medicaid fee schedule, and they earn $1,125,000. The health center's PPS rate is the same, $150 per visit. They have 15,000 encounters, so they would earn, they're entitled to earn from the state $1,125,000 in total. They also have some upside gain. Let's say they arranged with their ACO. Upside gain up to 75% of shared savings and potential downside losses of 25% of shared losses. So they could be at risk for up to $250,000 in losses. I find it helpful to divide the calculation up into two parts. I look at how much the state owes in wraparound, and then I do a separate calculation for how much the health center might earn or be obligated to pay back in payments under any incentive. And the reason why I calculate that separately is because, as I mentioned earlier, the state simply has an obligation to make a health center whole up to their PPS rate. If the health center wants to pursue a value-based arrangement where they take downside risk, either directly with an MCO or indirectly with an ACO, wherever it might have some payment obligation back to an ACO or an MCO, that risk falls on the FQHC. It does not fall on the state. The state discharges their payment obligations up to wraparound once they make their payment in full to the FQHC, ensuring that the health centers earn PPS for each visit. And that's why I separated out on the examples here. So here, how much would the health center earn in total? They could earn, the wraparound obligation is based on the total amount of money that the health center would have earned. So if you had 15,000 encounters, multiply it by $150 per visit, the health center could have earned $2.25 million. The health center earned $1.1 basically from the MCOs, leaving a balance of $1.125 million from the state in wraparound payments. So the total received is at $2.25 million based on having 15,000 encounters at $150 per visit. Next, the health center could earn another $750,000 if it manages that risk well and earns the upside gain, bringing their total to $3 million for the FQHC payment for services and the incentive payment. If they don't do well under this arrangement and they owe some money back to either the ACO or to the MCO, they may pay $250,000 back to one of those parties. Then they would have some financial obligation. And so let's deduct that $250,000 from the amount that they received in total in program income, and now they're down to $2 million. So they've used in this example some of their program income. Program income is the third-party revenue that they've been able to generate based on their operating a health center. They've used some of that to bear the downside risk in this value-based arrangement, which is permitted to do as long as it's a reasonable amount of risk that they're bearing, and it's in furtherance of their purposes of their project. So for this example, we're assuming that they took that downside risk to advance the purposes of the project, which mean ensuring care, preventing hospitalizations, diverting emergency room use back to the health center, and managing chronic conditions to avoid unnecessary hospitalizations and services. So even though the total $2 million under this example, because of the loss, is less than what they would have earned without the incentive arrangement, that is still permitted because it was on the health center's risk alone. Health centers took that risk alone in bearing that downside risk, and the state discharged their financial obligation by making the health center whole up to their PPS rate in paying that wraparound payment. The next example has to do with primary care capitation. A number of health centers are now being paid under what's called primary care cap, where the health center receives a capitated rate which is estimated to cover the cost of delivering primary care services. So in this very simplified example, let's presume the health center earns $15 per member per month from all the health centers, all the payers rather, all the Medicaid MCOs for delivering health services at the health center. Let's assume 9,000 member months, so they generate $135,000 in revenue from the MCO. Let's say the MCO also is paying the health center an incentive, and they pay a $3 per member per month incentive. And let's say, just to keep our example simple, let's say the health center earns the incentive payment if they achieve a level of NCQA, patient-centered medical home rating level 3. And let's say, for purposes of our example, they've reached that level of NCQA certification, and they've maintained it throughout the course of the contract with the payer. So let's say they earn the whole $27,000 that the health center received from the payer. So in this example, the health center would have earned under PPS $150 per visit. They had 2,500 encounters, receiving total revenue of $375,000. So calculate the state's wraparound obligation is the difference between what the health center would have earned under PPS, $375, deduct the amount they earned in primary care cap alone, $135, leaving a balance in wraparound to $240. The state pays that amount. Now the state has discharged their wraparound obligation because the total payments are now $375,000, which is what the health center would have earned in the absence of managed care under PPS. If the health center held true and earned their incentive, they earned another $27,000 on top of that, bringing their total to $402,000. If they didn't earn the incentive, they would have just not earned that $27,000 and would have earned a baseline of $375,000. So as you can see in these examples, if there's only upside risk and the health center doesn't earn the incentive, at worst they're just earning what they would have amounts they would have earned under PPS. The more difficult or sort of challenging or complicated example has to do with health centers that might be paid under something called professional capitation. As I mentioned in the first webinar, professional capitation involves taking risk for a broader set or a broader scope of services, sometimes even services that fall outside the health center's approved scope of project, because it could include some specialty care or emergency room services, depending on the health center's approved scope of project. But in this example, I'm trying to clarify the state's wraparound obligation. So in this example, let's say now instead of $15 per member per month that the health center in the prior example earned for primary care cap, now a health center is earning $50 per member per month for all professional services rendered to patients in the managed care contract. So they could earn, let's say they earned $500,000. In this case, you now have to do some kind of allocation for the amount of the professional cap payments that are paying for the FQHC services, versus certain services that the FQHC is paying to non-FQ, to other providers, to private providers, in furnishing those other professional services that are not part of the FQHC services. So for example, let's say a health center pays a specialty provider, a specialty cardiology group, and it pays them out of some of the professional cap dollars that it receives. So you have to now do an allocation between the FQHC services, and here I've allocated it $18 PMPM pays for the FQHC services, and then the health center uses the balance of capitation, here $32 per member per month, to pay for non-FQHC professional services. Now, it's helpful if the state does that allocation, or the MCO does that allocation, or an IPA does that allocation. Somebody other than the health center itself does the allocation of the professional capitation amounts that go to the FQHC versus non-FQHC, and that's sort of important because the allocation determines how much the state is paying in wraparound payments. So I would say a health center might incur some risk and additional scrutiny if the health center is deciding of that $50 PMPM, 18 goes to me for FQHC services, and 32 goes to me to pay for professional services. And the reason why you might be scrutinized is because the FQHC, if they estimate too low the amount that is allocated to them for services, the state's going to end up paying more in wraparound. So if you have a third party interposed where they are making the allocation between FQHC services and non-FQHC services, I think it withstands some scrutiny because it's viewed as a more independent judgment of who is making that allocation. So ideally, a third party makes that allocation determination. The calculation is going to be based on how much the health center receives, would have received under PPS. Here, that would have been $450,000. You deduct the amount of the allocated amount of payment for the FQHC services, which in this example is $180,000, meaning the state's wraparound obligation is $270,000, bringing the total payments for FQHC services to $450,000. But of course, in this example, the health center is paid at professional risk, professional basis, so it's paid $450,000 for FQHC services, plus that additional 32 PMPM for non-FQHC services. So the total amount a health center received was $770,000. Now, if the cost of all the services under the contract, all the professional services, FQHC and non-FQHC services, exceeds $770,000, the health center is, of course, going to incur a loss because the health center is paying those other providers, and if it pays them more than it receives, you're going to be in the red. You're going to have a loss. So the health center is still taking risk in this arrangement, in this kind of arrangement, and the health center is only being made whole by the state for its FQHC services. All right, I will leave some time at the end to take questions, and I realize that there's a question that came in, and I'll answer it at the end. So a couple of recommendations that you might be helpful to you in contracting under capitation amounts. Because states need a way to distinguish from you whether you are obligated to pay other providers and how much you're being paid for FQHC services and how much of the capitation is being used to pay other providers from that the FQHC is contracting with. It's very helpful for an FQHC in its contract with an MCO to separate out the amount of compensation that the health center is receiving for FQHC services and the amount of the capitation that is being paid over to the health center to allow the health center to purchase non-FQHC services. As I mentioned earlier, that allows for that third party, the MCO, to make the allocation. It's more likely to stand up to scrutiny by any state Medicaid agency or its auditors as an appropriate allocation if the health center is not doing that allocation themselves. So in some of the contracts I've reviewed, I have started to ask the MCO to allocate in the professional cap how much goes for the FQHC services and how much is going for the non-FQHC services. And because MCOs have data that allow them to do the allocation, because they've typically set the professional cap based on what their expenditures are likely to be to pay for the FQHC and the other professional services, they know in their claim system how to do that allocation, how much of that cap is likely to go to the FQHC for payment and how much of that cap should go to non-FQHC services. So that they're really in the best position to allocate the total cap rate accordingly. The other thing to do is to make sure that if you have payment incentives, regardless of whether they're earned on a capitated basis or some sort of pay for performance where they're earned after the fact based on how well you do on certain targeted clinical measures, make sure you separate out the incentive compensation from your base reimbursement so that it's clear to the state the revenue that you're earning for base compensation and the revenue that you're earning for incentive compensation. Because again, you want to make it crystal clear to the state that they should not be including in their calculation of wraparound any amounts that you have received for incentive compensation. All right, let's move to our last poll question of the day and show that. This question says, in negotiating a value-based payment methodology that includes a benchmark for the total cost of care, you would want A, the benchmark to be set as high as possible, B, the benchmark to be set as low as possible, C, the benchmark to equal the MCO's likely expenditures, or D, the benchmark to fall below the MCO's likely expenditures. I'll give folks a moment to answer that question. All right, we'll give it a couple moments, and then I'd like to show the results. And for the person who asked the question through the chat box, I see your question, and I'm going to answer it in the next section because it relates to that topic. All right, can we show the results from the poll? The answer to the poll question was A. You want the benchmark to be set as high as possible. Why? Because you want essentially to basically increase the chances are that you're going to generate savings. So the benchmark is what the expenditures are for the total cost of care. your spend or your allowed spend, whatever the managed care company refers to it as, is going to be, how much are actual expenditures. In order to create the biggest shared savings pool for you, you want there to be the largest difference between the benchmark and the expenditures for that population. So you always want the benchmark to be as high as possible to generate the potential for earning the greatest shared savings amount. If it's set too low, you're going to basically take away your opportunity to generate a lot of savings. I had a health plan that was trying to create an MLR somewhere around 76% of claims. That's pretty low. And if a health center was already, for the population, was already around, that amount or below it, then the health center would not have been able to generate any savings under the benchmark and earn any savings. So it's helpful to you that the benchmark is set as high as possible, not as low as possible, and you don't want it to be equal to the likely expenditures, and you certainly don't want the benchmark to fall below the MCO's likely expenditures either. You want the benchmark pumped up as high as possible to generate potential savings. All right, next slide. Now we come to alternative payment methodologies and how that relates to wraparound and to managed care. We received a question in the chat box about health MCOs that pay the full PPS rate to FQHCs under an alternative payment methodology. So first, you might wonder, why would that be an APM? How could it possibly be an APM if all the state is doing is directing the MCO to pay the health center their full PPS rate? It's an APM because the state has eliminated the wraparound process. So in 2016, in guidance that CMS issued to states, that is on the slide at the bottom, this CMS made clear that if the state is now directing their MCOs to pay the full WRAP payments to health centers, to full PPS payments to health centers to alleviate the state's requirements to do WRAP, that constitutes an APM in CMS's view. So the policy at CMS is that that's a kind of alternative payment methodology. The state has to submit a plan, an approved state plan. It has to make sure that the state is still at the end of the day paying PPS for all the health center services, and an FQHC still has the right to decline to participate in this kind of APM. So Illinois, I think, is one of the examples where the state submitted a state plan amendment to CMS, and CMS approved it, and now the Medicaid MCOs are paying full PPS to the FQHCs. And the question that came in was, does the state still have an obligation to reconcile annually to ensure that each FQHC received at least their PPS? And the answer is absolutely yes. The state still has an obligation under that state health official letter to ensure that the managed care company's payments comply with the statutory requirements of the APM, which means that the health center receives at least their full PPS rate for every encounter. Because as you and I know, managed care companies do deny payments for all sorts of reasons, sometimes because your claim got denied because there was something amiss in it, sometimes because you might see a patient and you might not be the assigned primary care provider, so the plan might deny it. You might have a new practitioner who hasn't been credentialed yet by the managed care entity. You might be out of network, all sorts of various reasons for why an MCO might deny payment from you and have the result be that you don't receive your PPS payment from the MCO. And it's in all those circumstances that a state has to ensure that they conduct some reconciliation annually so that they ensure that a health center has been paid in full at PPS for every encounter, every billable encounter, even if the MCO has not paid you in full for PPS. So absolutely, yes. All right, let's move to the next slide. So one thing is that if you are paid in any kind of alternative payment methodology, it's helpful to check every once in a while that your state is continuing to comply with all the APM requirements. So first they have to have, you should make sure that the state is actually paying at least PPS for every visit. And by keeping your baseline PPS rates adjusted for inflation, as PPS requires, and accommodates any changes in services in your approved scope of project. So as you know, you might have additional services that come with it into your improved scope, or you might just add on additional Medicaid services so that when your PPS rate, perhaps, it didn't include certain types of laboratory services, and now you're providing laboratory services. Or you've had changes in technology or how you deliver services that make your services take a higher cost or more timely, or now you're delivering, telehealth services that required an investment of additional resources or whatnot. Those could all possibly be changes in your services where under CMS policy, the state has to adjust your PPS rate due to changes in type intensity of services that you're providing. So the state continues to have obligations to adjust your PPS rates after they're established for inflation and for changes in the scope of your services. The state should make sure that the state is faithfully fulfilling their definition of the APM that's set forth in their approved state plan amendment. You still have the right to consent to the APM, so if you don't want to participate in the state's APM, you should have the right to revoke your consent and revert to the traditional PPS model. And lastly, as I mentioned in the last slide, the state still has to conduct some kind of reconciliation and oversight to ensure that you received in full PPS for every allowable, every verifiable encounter that you had. And I know this is a bit of a tussle. There has been some litigation that's occurred between states and FQHCs because sometimes, for example, states try to rely on MCO data for the number of encounters that the health center has without looking at the health center's own data for every for encounters that they had, and sometimes the MCO doesn't count all the valid encounters that should be accounted for in determining the total amount of payments that the state should pay or ensure that the health center receives payment for under PPS. So, for example, sometimes there's some sort of reason where an MCO might not have counted all the encounters that the health center had provided to patients, so they're undercounting the number of visits and not paying PPS in full. The state's process should accommodate and account for the fact that there were a higher number of valid encounters, and now the state has to make sure that the health centers are paid in full for those encounters, even though the MCO did not pay those encounters. How would this work under a capitated payment model? Let's say, for example, a state converts under an APM the PPS rate for an FQHC under an equivalent, just some kind of equivalent per member per month rate based on historic patient utilization and attribution. In this example, let's say the state continues to conduct quarterly and annual reconciliations based on actual utilization data. So they look at how many encounters the FQHC had, how much the health center was paid under the let's say in this case, from the managed care company as part of this APM and this PMPM payments, how much the health center would have earned under PPS, and if there was a difference because the health center would have earned more under PPS, the health center is receiving an additional payment from the state. Let's assume that the state continues to adjust the underlying PPS rates for changes in scope and for inflation. Let's assume the state did the right thing and received approval from CMS for a state plan amendment describing the APM. Let's presume further that the FQHC had the right to decline reimbursement under the APM and retain its encounter-based payment methodology. And let's assume that the FQHC could also change its mind if they agreed to participate in the APM. Under all those circumstances and assumptions, the state would have satisfied the requirements of an alternative payment methodology and would allow the state to make a capitated payment to the FQHC, direct the MCOs to pay a capitated payment to the FQHC for services. So an APM can be used both, like in the example raised by the question in Illinois, where a state directs managed care companies to pay the full PPS rate to health centers. A state can also direct the managed care companies to convert that PPS rate to a PMPM like they do in Washington State and have the health center receive their PPS rate in the form of a PMPM. But under all circumstances, a state continues to have an obligation to conduct some kind of annual reconciliation to ensure a health center has received at least the amount that they would have received under traditional PPS for every encounter. Medicare wraparound payments work comparable to Medicaid. You also have a right in Medicare managed care to any kind of to wraparound payments, regardless of whether you contract directly with a managed care company or indirectly through an IPA or an ACO. In fact, the Medicare regulations are quite clear that IPA contracts, those contracts where you contract indirectly with a Medicare ACO, also entitle a health center to wraparound payments. You are also entitled that any kind of incentive compensation that you earn from the MCO are held outside of the wraparound calculation by your Medicare administrative contractor. And in this case, the Medicare's obligation is to pay those wraparound payments at least quarterly, every 3 months, not four like in Medicaid, every 3 months under the Medicare managed care regulations. So some final concluding thoughts are, number one, health centers may participate in downside risk arrangements with MCOs. Nothing in federal law that we've ever found bars a health center from participating in downside risk arrangements, so long as you as a health center continue to comply with your Section 3 obligations that pertain to the use of federal grant funds and to your appropriate use of program income. If you do participate in downside risk arrangements, that's fine. It should have no effect on the state's obligation to make wraparound payments. That is, though that downside risk, just like any incentive compensation, is held outside the state's calculation of wraparound payments to the health center. And I encourage you to ensure that in your contracts with MCOs under value-based payment arrangements that you distinguish between the compensation for the FQHC services, the compensation that the FQHC might receive under professional cap for non-FQHC services, as well as additional compensation for any incentive compensation that the health centers earned. All right, I think we have only 1 minute left. I don't see any other questions that have come in, but I'm going to bounce this back to the NAC staff to let me know if there have been any more questions that have come in from participants.
Hey, Adam, this is Susan. No, I haven't seen any other come in. You had a very thorough presentation and answered all the questions along the way. So thank you very much for that.
Great, that's what I like.
If anybody has a question, they might have, you've got about, well, I was going to say about 10 seconds to enter into the chat box before 4 o'clock. But if you have any questions, you can certainly send them to us. You can send them to Adam directly. His email is up on the screen, or you can send them to us over at NAC as well. And just a reminder, I think Julie posted a note in the chat box that obviously today's webinar is being recorded and will be posted on the Health Center Resource Clearinghouse along with the slides, and then a notice will be emailed to everyone, all registered attendees, when the recording is available. And you'll also get the recording for the first session that way as well. So thank you very much, Adam, for a wonderful presentation today, and we look forward to seeing you on July 15th for our next presentation. Thank you all.